Hello, my name is Ian Macdonald. I'm Scientific Director of the Nestlé Institute of Health Sciences at Nestlé Research in Lausanne, Switzerland, and also an Emeritus Professor of Metabolic Physiology at the University of Nottingham in the United Kingdom. My job at Nestlé is divided between time actually in Switzerland in the Research Institute, and also some of the time working in Nottingham with Teams calls and the like in a virtual sense. Today's talk is about nutrition and the metabolic health of children, and the historical aspects of this are worth considering before we go into the details of the nutritional issues. So nutrition and health priorities, or metabolic health in children. Until the middle of the 20th century in most of the world, the concerns over health of children were to do with infectious diseases and to do with undernutrition. Nutrition has some impact on susceptibility to infectious disease if you have an undernourished child, or the ability to fight the infection. Whereas, of course, nutrition has a major, if not the only, real role as far as undernutrition is concerned. So, until the middle of the 20th century, nutrition certainly was a major contributor to a lot of the disease problems in children. Today, that's still the case, but there is an additional aspect which is potentially going to become even more troublesome over time, more troublesome than undernutrition does. And that is the issue of overnutrition and its consequences. And then underpinning both under and over nutrition is this issue of metabolic programming or epigenetic programming, which I'll come to later, which contributes to the overnutrition, but also contributes to the problems of undernutrition. So the outline of today's talk is to first of all give a brief summary of growth and metabolism in children, then to consider underweight and undernutrition, then to spend some time on the issues of overweight and obesity, and then finally to look at metabolic programming as it contributes to both of those, both to undernutrition and to overnutrition. So if we look at this slide, this is a very well-known slide in terms of the points that it illustrates. What we have here is the body mass index over time from birth through to 18 years of age, and this is the optimal, or the sort of ideal line here, where you have a rapid increase, rapid growth in the first 6 months of life till you get a peak in infancy, the infancy peak at around 6 months, and that's the BMI that you achieve here at the top of this blue rectangle. Then you get a drop in BMI as you get linear growth in children up to the age of about 4.5 or 5. And then at around that age, you start to get a rise in BMI again. And this is the point that's known as the adiposity rebound, because during that 6 months to 4.5 years period, the children are becoming less fat as they're growing in a linear sense and growing in fat-free mass sense, but not expanding their adipose tissue mass very much. And then from the age of 4.5 or 5 onwards, you get this rise in body mass index, which is partly driven again by more linear growth, more muscle fat-free mass accumulation, but also by fat accumulation. So that's why it's known as the adiposity rebound. And by the time you get to 18 years, then you are essentially at the adult body mass index, and it will normally be maintained at that level for some time to come. So this next slide shows the aspects of physical growth and how you optimally reach the milestones of growth. And so what we have on the left-hand side is a graph that shows that the BMI peak correlates with the body mass index that was there at around 9 months. So your the accumulation of body weight and the increase in BMI in the infant is a good predictor of what's going to happen later in life, and that is shown more clearly on these graphs in the middle and on the right hand side. The one in the middle is showing the consequence of an early adiposity rebound. So that's the dashed red line here. And the adiposity rebound is starting at about 3.5 or 4 years of age. And you can see then by the time the child is 10, it's accelerating up through the centiles and really getting a rapid increase in body mass index. Whereas the late adiposity rebound at around 5 or 6 years of age has a much slower trajectory. And so you've got quite a big difference at the age of 10. And if we look how that might relate to the later in life, the body mass index, what you have here is that the high body mass index at 6 years was, as you see there, was certainly predictable by the accelerated peak during infancy, whereas the low body mass index at 6 years was associated with a much lower peak at infancy. So there are two messages here. One is that if you overfeed a baby, an infant in the first 6 to 9 months, 6 to 12 months of life, you're likely to end up with a larger child and be progressing towards obesity. And if you start to overfeed them during the toddler years or just beyond, then you can also do the same thing. So it isn't just infancy, it's infancy and toddlerhood where the care needs to be taken in not over-nourishing a child. What is metabolic health and the relevant growth in early life? Well, if a baby or an infant has sufficient nutrient intake, then you're going to get optimal development of bone and its mineralization, physical growth in terms of weight and height, reaching the milestones, organ development in terms of pancreas, liver, the endothelium within the vascular system. The endocrine system and growth factors will develop effectively, and glucose homeostasis, body composition will also develop in an optimal way. So optimal growth, metabolic health are associated with a sufficient nutrient intake. The two things that have not really been recognized until recently are the fact that the microbiome in the child's intestine, especially the large intestine, has a big impact on these health outcomes. And so the diet isn't just feeding the baby, it's feeding the microbiome, and you need that for optimal gut health, but also for appropriate positive influences on glucose homeostasis, cardiovascular system, and a variety of other these factors. And this epigenetics thing, which is illustrated here with the yellow circle, this is the potential harmful effect of inadequate nutritional intake upon the genome of the child, and the potential for effects altering gene function and leading to overnutrition, leading to susceptibility for chronic disease. So the microbiome that I just mentioned is illustrated here in terms of the sorts of factors that can affect it. So during neonatal feeding, the provision of nutrition will have effects upon the gut microbiome and also have effects upon hormone secretion, of course, in terms of the factors I've just talked about. But the important thing is that the gut microbiome will release short-chain fatty acids through fermentation of components of the diet, as well as other metabolites. And these can also have effects within the body to influence hormone secretion, affect growth, body composition, and metabolic programming. And those in turn can have an impact upon adult health, adult metabolic health, and susceptibility to chronic metabolic diseases. So having a healthy gut and a healthy microbiome is as important for neonates, infants, and toddlers as it is for adults. And so it's important to think of the integrative approaches of the gut with the baby to better understand the dynamic interactions between the early life environment and the impact on long-term health. The thing is that much is still to be identified in terms of the science underpinning this and the nutritional interventions that may be of benefit to babies, infants, and toddlers still need to be developed and validated. But the science, as far as it goes at the moment, is very exciting, but it still needs a lot of hard work to find out which products will be most effective at ensuring optimal development of the gut microbiota, as well as optimum development of the baby. When we're talking about physical growth, and this is leading on to underweight and undernutrition, what you can see here are 4 panels. On the top left, panel A, is where the child is underweight at the age of 15 to 18. And looking backwards to see what they were like at birth and how it's progressed over time, you can see that at birth, very few, hardly any of the babies who become children aged 15 to 18 with underweight, hardly any of them are overweight, and not really any obese to start with. Most of them are normal weight, as you can see here. But as time progresses and nutrition, environmental factors are not optimal for growth of these children, then they start to lose weight essentially, and you get fewer and fewer who are normal weight and more who are underweight. So it's a progression from about the time of this adiposity rebound onwards, that there is inadequate nutrition and inappropriate environmental factors from here on in. And that's when you get to 14 years, you still have some of them are of normal weight, but the time you get to 15 to 18 years, they're all underweight. Normal weight children, most of them start off normal weight, and it gets more and more obvious that they're normal weight by the end, but that's almost by definition. The 2 that get really interesting are these here. What you have again is a small proportion of these children are overweight or obese initially. It starts to increase, the yellow diamond shape starts to increase at the adiposity rebound, and by the time you get to 14 years of age, you've got more overweight kids than you have normal weight kids. And by the time you get to 15 to 18, they're almost all overweight. And then on the bottom right-hand panel, the same is true for obesity, although you can see here that there's an earlier adiposity rebound in terms of the BMI starts to go up from the age of 2. And by the time you get to 14, you've got 75–80% of them are obese, and almost all of the remainder are overweight. And by the time you get to 15 to 18, they're all obese. So amongst obese adolescents, the most rapid weight gain had occurred between 2 and 6 years of age. And the important thing then is to look at that point in time as well as the teenage years. It's almost too late to prevent it is too late to prevent the acceleration of BMI in the teenage years, because most of it has already been triggered in the earlier stages with this early adiposity rebound. So focusing on good nutrition, not trying to avoid overfeeding in the early years of life is really very important here. And if we look at the link between the cardiometabolic disease risk and obesity, or markers of obesity, then there's some interesting things to observe here. On the left-hand side, the x-axis of these plots is birth weight, from less than 2.5 kilos through to more than 4.2 kilos. And it's also divided by ethnicity here. And so if you look at obesity and markers of obesity, then the heavier ones are certainly, in all of the ethnic groups, the heavier ones tend to produce children with a higher waist circumference. And there is some difference between the ethnicities, but not a great deal. The markers of cardiovascular health, it is somewhat different in that the smallest babies in most of the ethnic groups have got the increased systolic blood pressure. The exception being the Mexican and Hispanic kids, where actually the smallest and the largest at birth have got this elevation in systolic blood pressure. Then on the right-hand side, these indices of obesity, the high waist circumference, in most cases, the smallest at birth have got the lowest waist circumference, and the highest birth weight have got the increased, and there's not a lot of difference between girls and boys, with the exception of those of black ethnicity, where you can see that in particular the boys who had the lowest birth weight have got a higher than optimal waist circumference, and it's not very different to the boys' waist circumference of those who had the highest birth weight. Whereas with girls, it seems to be a progressive increase from being a low waist circumference with the smallest babies when they're girls, up until the highest one with the largest babies. So there certainly is a somewhat variation in the risk with birth weight, but also with some aspects of ethnicity. So as far as underweight and undernutrition are concerned, with underweight, we need to think about whether or not the child is small or just short. And so it's not just a question of weight, but it's also of height and weight in relation to height. And of course, genetics could well play a part here. So we need to know how tall the parents are, because if you've got very short parents, you're not going to be a very tall child and adult yourself. More importantly, what is key to evaluate here is whether the child has dropped down the centiles on the growth charts, or if they're just they were born on the 5th centile and they're still on the 5th centile by the age of 8 or 10, because then you have someone who is sort of genetically small, almost certainly. There is greater concern if you've got a baby who is underweight at birth, but then has rapid weight gain as an infant, and the potential problems that can lead to due to metabolic program effects that I'll talk about a little bit later. But that's the sort of problem that we also were concerned about in those earlier graphs I showed you about timing of adiposity rebound and development of obesity as a consequence. The undernutrition aspect, one of the things you need to think about is whether in chronic undernutrition, whether it is food and just an inadequate amount of food, or whether it's a poor quality diet in terms of being deficient in specific nutrients. And so you could get inadequate growth if it was a shortage of food, and so you get height and weight effects, so you get stunting and low body weight. Or you could get impaired metabolic function if it was specific nutrients that were inadequate in the diet, such as deficiency of iodide, which could affect thyroid status, and also in an infant, neonate and infant, could affect neurodevelopment. So chronic undernutrition does not necessarily mean the same thing, depending upon what component of the diet it is that's inadequate. If we move to obesity, then it is now being termed the obesity epidemic, which may be a slightly unfortunate term, especially given the epidemic of infectious disease that the world is suffering from at the moment. But I'm afraid obesity epidemic is a term that is here, and it's unlikely to change. But what it's saying is that there is an increasing incidence of obesity around the world, and no country is protected against it. Factors that contribute to it seem to be a lack of breastfeeding and early weaning in particular, as well as not breastfeeding, the quality and quantity of the diet, so early introduction of complementary foods below 4 months, high intake of sweetened beverages, low intake of fruit and vegetables, habitual food away from the home, so lots of fast food consumption in fast food restaurants and so on, and lack of family meals, so the kids are just left to eat on their own or eat in front of the television with piles of snacks and sugary drinks next to them. Lack of responsive caregiver feeding behaviors, so low attention to hunger and satiety cues, use of overly restrictive or controlled feeding, which has a negative effect to cause sort of overconsumption whenever that restriction is lifted. Low nocturnal sleep duration, TV screen viewing time, which as a consequence causes decreased active playtime, and social deprivation. This happens in many countries, but some of you will be surprised to hear that it is a major contributor to the development of obesity in a developed country like the United Kingdom. This is taken from the UK National Child Measurement Programme, which is still going on, but the data I've extracted were from 2006 to 2012, but the data since then just make the picture look even worse. What we have here are 5-year-old children. So these are children entering elementary school or primary school. And what you can see, each one of these histogram bars from the sort of pale through to the dark brown is a year. And this is all children of that age in the country, unless the parents objected, were measured, height and weight. And you can see that the least deprived areas, if anything, are getting better over time with a reduced obesity prevalence, whereas the most deprived areas had a high obesity prevalence and it has not changed. That's in the 5-year-olds. If you look at the 11-year-olds, it's even worse, because in the 5-year-olds, the obesity prevalence was about 12% in the most deprived, and about 7% in the least deprived. Now we have 11% in the most, 12% in the least deprived, and 23% in the most deprived. Children have obesity, and it has been getting worse over time in this most deprived group. So it is not just an issue about an environment which provides too much food. There's also an issue about deprivation, which leads to inadequate physical activity and excessive food consumption. Industry has a role to play in the obesity epidemic, and some people will say it is the prime cause of the epidemic as well, but I think there's no real evidence to support that. So everyone plays a role in the obesity epidemic: town planners, parents, schools, and industry, as well as many other stakeholders. If the food industry does not define a role, it may be defined for them, and there is already pressure for legislation in terms of the composition of certain components of the diet. The challenges and charges to industry range from social irresponsibility in marketing things to children to potential legal action. Sources of the challenge come from a broad range of stakeholders, the government, interest groups, activists, and the dialogue on a solution continues to move from food to include diet and lifestyle, from treatment to include prevention, from isolated responsibility to inclusion of all stakeholders, including the food industry. So the food industry really does need to take this seriously and to act appropriately and responsibly in helping to prevent further development of childhood obesity. It is important to think about infancy because in terms of poor dietary patterns, the problem starts in infancy and contributes to that early adiposity rebound that we saw in the earlier slides from 2 years onwards. So undesirable dietary practices are associated with obesity are already present in infants. By 2 years of life, the child has assumed the eating practices of the family, although hopefully the rest of the family don't end up with most of the food on their face, like this little baby has. And by 2 years of life, BMI is predictive of obesity in childhood and later life. This is a really interesting plot of the percentage of energy from the major food groups over time from birth to 4 years of age. And what you can see here is by the time you get to 18 to 20 months, so that's this histogram here, you've started to get a stable contribution of the two green bits here, which is fruit and vegetables, and they are tiny. So you've got about 7, 8, 9% of energy intake is derived from fruit and vegetables in these kids. And you start off with a lot of milk or formula, and then of course it diminishes and grains start to make a contribution, and meat and juice and other things. But fruit and vegetables is pretty stable from 6 to 8 months onwards if you look at this, and it's certainly very flat by the time you get to 18 to 20 months, going through to 4 years. So it's remarkably constant, and it's setting the stage for long-term dietary patterns. And as you know, the fruit and vegetables are generally speaking much less energy dense than some other components of the diet, and so the fewer fruits and vegetables you have, the likelihood is that the diet is more energy dense and the potential for overconsumption of energy is greater. So then I think what we need to do is to sort of think about the summary in relation to childhood obesity. We're in the midst of an obesity epidemic, which affects everyone. Undesirable dietary practices are already present in infancy. 2 years of life, the child has assumed the eating practices of the family, and their BMI is predictive of obesity in childhood and later life. And infant obesity is now in pediatrics a diagnosis. So interventions to curb obesity should start early in life and address the whole diet, because treating it is just very demanding of resources and not very effective. So preventing it is critical rather than treating. The final thing I just want to briefly cover is this metabolic programming issue. So it starts in preconception by what mum is eating and what her history has been. Most of it is thought about in relation to the gestation period, where inadequate growth, intrauterine growth retardation is a major factor for then altering the programming of the genome, epigenetic effects leading to potential problems later. Lactation or short duration lactation, feeding in infancy, and then toddlers and preschoolers. These are all times at which the diet can contribute to programming the metabolism for later life and have persistent influences on chronic diseases, as are illustrated here. So with inappropriate nutrition in each of these points of time, you have an increased risk of metabolic and cardiovascular diseases. And so the metabolic system, insulin resistance, glucose intolerance, dyslipidemia, and obesity are things that can more easily develop. Hypertension, heart disease, stroke, and atherosclerosis in the cardiovascular side, and other systems are not without problems as well. So this metabolic programming has potentially major effects on chronic disease in adult life. And what we have here is an illustration of the critical periods of development and the lifelong significance. So in pregnancy and preconception, things that happen to mum, as you can see up there, can have an impact. In the fetal stage, then genetics and the intrauterine environment can give rise to these epigenetic modifications and alter tissue and organ remodeling, so that then you get to the postnatal stage, you can get impaired growth and development and stunting. And in long term, you get these chronic disease outcomes, overweight, diabetes, cardiovascular disease. And then in the middle, the programming of tissues is part of the mechanism underlying a lot of these chronic changes. Inadequate muscle mass, inadequate beta cell mass in the pancreas, kidney not developing properly, insulin resistance, low glucose uptake, fat accumulation, altered neuronal development, altered appetite control. So the metabolic programming aspect of things, due to inadequate nutrition or inadequate exposure to, or inappropriate exposure to other factors during the early stages of life, are really a major cause of concern. And this one here just illustrates what can happen. So in the fetus, the heart can get remodeled, the intima thickness can change, atherogenic lipid profile, loss of nephrons in the kidney. In the child, cardiac things can also develop further, blood pressure can rise, and then you can get continued alteration in the cardiovascular system over time. So it is a real problem, a real concern, and illustrated by this graph at the top here, where these are pounds, not kilos. I'm sorry about that. So this is just over 2 kilos, 2.5 kilos birth weight here. You've got a 1.5 times greater risk of dying from coronary heart disease before the age of 65 than a child that is born at about 4.5 kilos of birth weight. So it's a serious problem in terms of the fetal growth restriction and the impact on metabolic programming. So in conclusion, in the mid-20th century, the main priority for childhood nutrition was to prevent undernutrition and provide an adequate nutritional status to help children deal with infectious diseases. This is still the case, but it's becoming of major, maybe even greater importance that overnutrition and metabolic programming in fetal and neonatal life affect the child, but also have long-term consequences into adulthood. Food industry can make a major contribution to enable children to achieve optimum growth and health by the provision of appropriate nutrient-rich, energy-poor foods. However, the industry also needs to recognize that inappropriate consumption of these energy-rich and nutrient-poor foods can contribute both obesity and specific nutrient inadequacies. And a major challenge going forward is to develop a strategy to help children and their caregivers make appropriate choices for the long term of health. Thank you very much.